you asked for practical advice, and that is the purpose of this masterclass. The problem with calling them medically unexplained symptoms, and by the purely medical model they are unexplained, is that it gives us the ability to say, we don't know what it is, so there's no treatment. Certainly there is no drug treatment, but there are two schools of thought, as we explored last year, and one to say, we don't know what it is, there's no treatment, we need more research to find out what the pathology is underlying this and to discover the treatment, and then we'll be able to do something. But moving beyond the medical model and acknowledging the mind-body connection and seeing these disorders as being collectively linked as disorders of function of the central nervous system. The problem with this approach is that almost invariably all the patient hears is, it's all in your head. So two things have become clear to me. Firstly, that the existence of this uncertainty and the dichotomy of thinking is letting these people down. Whichever way we approach the symptoms, these are real illnesses causing real and often significant disability. And secondly, that the scale of the problem is massive. Up to 30% of all GP consultations are for medically unexplained symptoms. Up to 50% of all hospital outpatient clinics in every single specialty are for medically unexplained symptoms. As I pointed out last year when I was having this discussion with Mark Lane and Jonathan Christensen, Mark said that in his gastroenterology clinic, up to 50% of his time is spent dealing with patients with non-specific abdominal pain, and Jonathan said that 50% of the clients, the patients he sees in cardiology clinic, are for non-cardiac chest pain. So I presented these views to a group of medical student leaders recently, and once I'd finished, a hand shot up at the back. This very polite young man said, "Thank you, that was really interesting and well presented, but we cover this in our curriculum." I personally am on a journey to understand the implications for all of this in the way that I practice, and I suspect many of you too. But our medical students, thankfully, get a head start. I'm excited for this session to further my journey, and we have three experts in the field who work together as a team to address these problems. So if I could just introduce Professor Chris Kenedi, who trained at Duke University Medical Center in internal medicine and psychiatry. His family came to New Zealand for 3 years, 10 years ago. Duke appears not to have noticed, and he retains a faculty position there as an associate professor of both the departments of medicine and psychiatry. At Auckland Hospital, Chris is a general medicine physician in the morning and a liaison psychiatrist in HIV in the afternoon. He is the medical advisor for the inpatient psychiatric hospital and works in HIV neuropsychiatry and clozapine toxicity management for the DHB and the coronial system. He is the neuropsychiatric consultant for the Civil Aviation Authority of New Zealand. Actually, do you know what? He also assists ACC in Wellington with external review of patients with complex and somatoform disorders. His research interests are factitious and somatoform disorders, mental health in the aviation community, and clozapine toxicity and prevention.
Thank you all for being here. Over the next 6 or 7 hours, we're just going to give you a little taste of what the issues are that you need to consider when you're dealing with some of these patients. I've been practicing as a consultant for about 11 years now, and I previously was head of the diagnostic service at Duke. And I know when I finished my training that dealing with patients with medically unexplained symptoms or somatoform disorders or functional disorders were some of the most challenging patients because of the helplessness that I experienced. and because it was hard for me to connect with them, and because I was often managing my own fears about missing something, or am I being helpful, or am I engaging in that sense of helplessness? And part of what we're here today is to try and give you some confidence and strength and skills and knowledge so you can go into a room with these patients, because you will all see them in whatever field or subfield you're in, and you can go into that situation and feel confident about what the first steps are, and then Christy and Megan will tell you what the next steps are. So we're going to throw out a case. I just happened to get this call a few years ago, and an immunologist called me and said, I've got this lady with CVID, and I just have a question about what antidepressant to choose for her. And I was like, okay, well, just give me the number, and let me look up her file. And she has a few other issues, it turns out. And so I'm going through these issues, and my eyes are watering, and I pick out that there's a few of them that are slightly unusual, and that seem to form a part of a repetitive pattern. And that's one of the key take-home messages of this session. The diagnosis of a functional disorder of medically unexplained symptoms is based on the pattern of the patient's presentation, not on any specific smoking gun or magic bullet that you find. And that it's the pattern and seeing the pattern and recognizing it that tells you what's going on. A second take-home message is that you can have ticks and fleas, that this patient has actual CVID. They haven't mimicked it or fabricated it, or the clinicians haven't made a mistake, but they have CVID and a functional disorder. And that there's no reason you can't have both. As a matter of fact, what we now understand is that the people with the highest rate of non-epileptic seizures or pseudoseizures are actually people with epilepsy. The people with the highest rate of non-cardiac chest pain are people who have coronary artery disease, and often those who have had MIs. That it is the medical experience that brings people into contact with their symptoms in their body that actually makes it more prevalent for them to experience these functional feedback disruptions that we'll talk about. So this lady, just to emphasize, she had these recent services that were involved and previous services. She had pretty much seen everyone under the sun in the hospital. And that really told me what was going on here. And it said, look, there's a lady with CVID, which is a complex multi-system disease, and she's also experiencing these functional symptoms. What can we do to help her? And that's why we take a step back, and we say that a functional disorder is a disorder where there's excessive worry, like health anxiety, or discomfort, such as pain, or bowel disruption, or fatigue. And that's one of the third key take-home messages to understand. What we've learned over the last 10 or 11 years, primarily in Europe, I have to say, and I'll talk about that at the end, is that all functional disorders are the same. That they present in different ways, but they're related to the same neuroanatomy and neurophysiology. It does not matter if you have chronic fatigue, fibromyalgia, chronic pelvic pain, where there's obviously not a cancer or a nociceptive stimuli, or irritable bowel syndrome, or gastroparesis. These are the same disorders that relate to disruption in the feedback system between the anterior cingulate, the prefrontal cortex, and the limbic system, and the organs. When David talks about patients saying it's not in my head, they are right. It's not purely in their head, but it's also not purely in their gut or their joints or their immune system either. It is the connection and the disruption in feedback between the two of them, between the CNS and the somatic organs, that leads to their distress and their discomfort. That is the essence of the functional disorder. And a reductionistic view of focusing only on the bowel symptoms or focusing only on their psychology or their neuroanatomy is going to leave you bereft of your ability to effectively assist these patients. So as David said, the prevalence is very high. It's almost overwhelming sometimes for clinicians to hear this, that a quarter to a third of patients in primary care, a fifth of patients in the hospital, and a third of patients in neurology will have functional symptoms. That doesn't mean their only complaint is functional, but it does mean that there are functional systems that are contributing to their neurology visit or their hospital admission. And this is a study from Kroenke, which just shows that the patients in blue, so the line shows the patients that presented to GP practices. And the patients in blue are the ones that 1 year later had any diagnosis for their symptoms. And so the red are the patients where there was never any diagnosis for those symptoms. And this is just local data showing that New Zealand is not an aberration, that we're a microcosm of the greater world and the data we find in terms of the systems that are affected in functional disorders. So how do you make the diagnosis? And this is a key slide for sort of understanding that one of the main issues is localization. It's not any one single aspect of this. None of them is a gotcha moment. It's the pattern that we see together that helps us to effectively make the diagnosis. Vague localization, vague intensity, hard to delineate periodically. It's hard to pin them down about alleviating or aggravating factors or about timelines, that there will be often many symptoms. The symptoms will tend to be unspecific. The characteristic of the symptoms will tend to be slightly different than you would expect for the nature of the disorders that they're asking about or that you're concerned about, and that it's sometimes hard to pin them down what the main symptoms are that are causing the disruption. Remember, everyone's allowed to have functional symptoms, and you all do. And the data suggests that you all have functional symptoms in your life. That's a normal part of the human experience. Just like it's normal to have dissociative symptoms in your life. Who here has had a psychotic experience? Come on, you were all young once. You all have had a psychotic experience. I know this. How do I know this? Because disassociation is a psychotic experience, and you've all disassociated. Maybe it was when you were eating a bag of crisps, and you were eating the crisps, and part of you was saying, oh, I should really stop now. And the next thing you know, you feel your hand hunting around, and you're like, crap, I ate all the crisps. I didn't mean to. That's disassociation. Your cognitive mind, which only represents around 200 years of evolutionary development, is saying, let's stop eating crisps now, Chris. You just got back from the gym. Let's make something of that. But your emotional mind, or the subconscious, which represents 400 million years of evolutionary development, is saying crisps, crisps. In general, your cognitive mind is the rider, and your emotional mind is the elephant. And when the rider says, go to work, wake up, do a task, complete maths, plan, you do it, and they work together. And they're completely integrated in how they are. But when the elephant, the emotional mind, the subconscious, is angry or scared or horny or hungry, the elephant is sometimes going to do what the elephant is going to do. You've hopefully had the experience of yelling at someone you truly care about. And as you're yelling at them or as you're saying things to them, part of you is almost having an experience thinking, oh my God, that's a horrible thing to say. Or I'm going to pay for that later. I can't believe I'm actually saying this. That's an out-of-body dissociative experience where your cognitive mind is saying, whoa, this isn't such a good idea, but that elephant is charging ahead. Or you've kissed someone that you knew maybe it wasn't such a good idea, or you've eaten something you shouldn't, or your fear caused you to pull away from something that you knew you needed to do. Those are all normal dissociative psychotic experiences. But you don't have a disorder because those dissociative experiences don't impair your ability to function. It's only a psychotic disorder if you have so many experiences recurrently, or they happen at times, that it impairs your ability to work effectively or to hold a relationship or to engage with society effectively. Then you have a disorder. So it's the same thing is true with functional symptoms. Patients have functional symptoms. It only becomes a disorder if it impairs their ability to function in a relationship or a job or effectively engage in healthcare or in some other way. And understanding that is critical because we don't want to pathologize things unnecessarily. We want to recognize when there is a disorder, when those patients do have symptoms that are impairing them, but we don't want to overcall and overlabel people in that setting. Is that coherent-ish and coming across? Okay. So, the trajectory is that patients start with sensations and worrying, which we'll all have in our experience. Symptoms, they present with the symptoms, it's bad enough, they go ask for help. They get investigations. They sometimes get referred. Unexplained, they get sent back. We don't really find anything. It's like when you come into my emergency room in Auckland and you're like, I have chest pain, and I see you the next day, and I'm like, you don't have an MI. There's no pulmonary embolism. And I'm like, I'm really excited. And you're like, well, that doesn't really help me. I have chest pain. It was bad enough that I left work and came in here to the hospital, and we're having this disconnect. I'm excited that you're not dying, you're not having an infarction, and you're like, well, WTF, what's wrong with me? That doesn't really help me. And it gets worse. And then some patients will continue to go along this trajectory. They'll get overtreated. They'll meet some practitioner who wants to be a hero, and don't go to a surgeon if you don't want an operation. Don't go to a gastro if you don't want a scope. And someone's eventually going to put a hole in them, or give them a medication, or MRI them and find an incidentaloma. And it goes on, and then we're off to the races. And if it's not caught, it leads to disability, permanent labels. It becomes part of their identity and becomes intractable. You can be the stop for that. You can be the person who, along the way, says, let's take a moment of pause. These symptoms, this pattern doesn't make sense. You don't have to label them and say, this is a functional disorder at the first call, or even when the pattern starts to come into your mind. It has to be part of your differential. It's like I tell my medical students that if your consultant is pimping you with questions you don't know what to do, you can always throw out, lupus, HIV, endocarditis, syphilis, sarcoid, the great pretenders in medicine. And it's sort of a joke, but it's not. Because if you don't think about those things in the back of your mind, you'll never make those diagnoses. Functional disorders are the same. Do I make the diagnosis when I walk in someone's room as a gen med physician on a busy round on a post-take, and I say, oh, this is clearly a functional disorder on my first time seeing the patient? No, of course not. But if things start to not make sense during the round, and I look at the patient's history, and there's a pattern of admissions and visits and tests that don't make sense, I do start to think and say, this is on my differential diagnosis. I tell the patient, I have some concerns about what's going on, and there may be a feedback issue, a functional issue in terms of how the brain and body are working that are causing you to have real symptoms and real distress. And I want to make sure we're not ignoring that in the differential when we send you back to your GP, that I want to make sure it's considered, because I want to make sure we're doing the right thing for you. And that's where this comes in. You're not going to have time necessarily, depending on the length of time and the setting of your care, to do this with every patient. But these are key features in looking at how you can engage with your patient and how you can understand whether this is a functional disorder and what to do with it if it is, and how that leads to treatment planning. That you want to make sure you do a good review of systems and not just the chief complaint. You want to ask how their actual functionality is. It may just be, what do you do when you're not in the hospital? What do you do with your day, or how have things been going, or are you able to, are you able to take care of your kids? Are you able to do your job? You want to ask some questions about onset, if there's time, about family illness and illness behaviors, and about prior experience with the healthcare system. So the biopsychosocial framework is about not being reductionistic. It's about trying to see the person as a whole and understanding that there are vulnerabilities. You can have functional disorders in the families. You can have anxious, perfectionistic traits, long-standing stress. We know that adverse childhood experiences, like you learned about yesterday, are one of the key features, and I'll talk about those in a second, in terms of creating vulnerabilities in the feedback system. And then there are triggers that go forth. And then you get the symptoms onset that lead the patient into you. And I'll give you an example of this. A person is brought up, and they are subject to emotional abuse and neglect by parents who are have their own stresses, or busy, or using drugs inappropriately, or alcohol inappropriately. And that child grows up in a world where things just don't always make sense, where they're blamed for things that aren't their fault, the parents are unpredictable, and during that 0 to 8 period, they grow up like a cat on a hot tin roof, on tenterhooks, okay? And they live in a state of hyperarousal, and they're just constantly aware. And those people tend to make very good doctors and pilots and IT managers, because that hyperarousal is a benefit. It allows you to anticipate problems so you're not blamed for them. It allows you to see patterns ahead of time more than most other people can see, and it allows you an advantage often in your occupational performance if you use it right. They often become therapists or salespeople because they're often able to see 8 to 12 colors of the emotional rainbow, whereas most people could only see 6. They can see people's reactions sometimes before the people can see it themselves because of that hyperarousal in terms of their limbic emotional cingulate system. But that hyperarousal is not only external. That hyperarousal can also be internal. And they can also be more aware of their own internal somatic symptoms. That's why people with functional disorders always will have more drug reactions and allergies than the average bear. They will always have sensitivities and responses that are in the rare side, and that's why multiple chemical sensitivity is a common analog of functional disorders. So you get these patients, and this sort of explains chronic fatigue. You get these patients, and they have this hyperarousal state they live in. They're very functional, and they go through and they use this hyperarousal to their benefit. They're often quite high functioning and engaged. And then they get an infection, a virus. And that's what, so many patients tell us, oh, I was fine until I had this virus. And the virus becomes the key point. And what does the virus do? It upregulates their immune system. The cytokine release goes through. They feel like crap. They feel all these pains. Because of this hyperarousal, they feel more pain in every joint at a higher degree. And we know this from quite a few studies in Germany, that people with increased adverse childhood experiences, people with functional disorders, both feel pain at higher rates and can tolerate pain less than people without adverse childhood experiences and without functional disorders. And they have this experience. And what happens? The cytokine release and feeling like crap and the joint pain and all the symptoms of the virus trigger their sympathetic nervous system. It triggers their limbic response and their fear response. Maybe something really bad is happening to me. In the elephant, their cognition is down, oh, I just have the flu, this sucks, I'm just down, I'm feeling vulnerable. But the emotional mind, the subconscious mind, is triggering alert, alert, alert. There's something going on, there's something wrong. And it triggers that sympathetic nervous response. And that overactivates the immune system and leads the immune system to secondarily lead to over-response. And it leads to a disrupted feedback flow. Whereas most people, when the virus is gone, the immune system downregulates. But for some of these patients who get caught in this triggering system, they start to feed each other. And the nervous system feeds the immune system, feeds the responses, and the nociceptive system, and you're off to the races. And it just never subsides. And they live in this constantly triggered state that they're responding to their environment in a way internally through that hyperarousal. And that's an example of triggers on a vulnerable person. And then there's maintaining factors. They will have maladaptive beliefs. Maybe they'll go online and they'll read about adaptive pacing or take it easy or go through, just the same way with back pain. Whereas we know that patients who have disc injuries who lie in bed are less likely to recover, take longer to recover than patients who engage in motion. You get a similar kind of problem. These patients with fatigue and with functional symptoms tend to engage in activities that maintain their symptoms and maybe get unnecessary labels or unnecessary explanations and perpetuate these beliefs. And if they don't, then we tend not to see them, right? So by definition, we're seeing the ones who are inherently oriented towards maintaining them. And the system sometimes contributes to doing this. And that's where you get what the Europeans call chronic bodily distress syndrome, the Americans call somatization disorder, and most people, we agree on functional disorders is the main thing, that it goes both ways, that you can go, it's not a one-way pattern. We can bring people back up by understanding their vulnerability, by understanding their triggers to manage these things. And there are protective factors that help people. And things like engaged doctors, like having a clinician who listens to them and is compassionate and says, I believe you're having these symptoms and it sounds awful. That is therapeutic in itself, and that's a key take-home message. A good assessment, an engaged clinician, is the first step of therapy. You don't just need to go to professionals for the next following evidence-based stages. You can be the first step of helping them to get better. Just an example, 2 quick cases you might see in your practice. Elite sportsman, a marathon runner, pushes himself, ignores bodily symptoms as he gets older, develops an allergy to peanuts, which is immunologically proved allergy, and then develops these symptoms. And these allergic symptoms spread. There's no clear connection. And he starts these maintaining factors about it. He starts isolating himself. He starts going through boom and bust. I'm all fine, and he goes back to 100% activity, and then suddenly finds that he's overwhelmed, and his elephant is overwhelmed, and he says, no, I'm sick. And he just goes back and forth between the 2 roles. And part of your role in that kind of patient is getting them to do things in a graded way. And Megan and Christy will talk about that as well. Everyone sees functional somatic symptoms. And again, it doesn't really matter where it manifests itself, whether it's IBS or fibromyalgia, chronic headaches, Globus syndrome and ENT, and so on and so on. And I'm not going to go through this. And that's for the next 2 hours in terms of understanding. But there is a lot of science and sort of understanding where we are now. Most of it has come through the last 7 years in terms of pulling together pieces of work that have been done previously about understanding how this functions in the brain. But it's, again, not purely about what's going in the brain, but the connection between the brain and the body. And we know that adverse childhood experiences and early trauma, what we sometimes call complex PTSD, as opposed to acute PTSD we associate with combat or rape or assault. But complex PTSD, which is that early childhood developmental trauma, it's been understood since the 19th century. It's not like a new great idea that's come out. It just we haven't really known what to do with it. And until the last few years of functional MRI, we haven't really understood some of the connections with it. But we know that 2/3 of women with idiopathic gastroparesis report prior physical or sexual abuse. We know that 30% of urticaria that doesn't respond to any kind of medical intervention, including steroids, does respond to psychotherapy. We know that childhood abuse is associated with high rates of fibromyalgia, chronic non-cancerous pain, and chronic fatigue syndrome. I'll give you an example of my experience and what I think hopefully illustrates the value of a good assessment. 38-year-old female, shell fell on her head, no loss of consciousness, but since then she's been effectively disabled, diffuse pain everywhere, not just the head, fatigue, calculation concentration difficulties, bilateral arm weakness, IBS symptoms. This is clearly someone with what we would call severe bodily distress syndrome or somatic symptom disorder, that the symptoms just have no relation to the mechanism. But the symptoms are very real. This isn't someone just looking for a paycheck or malingering or fantasizing about them. She's really experiencing them. And when I went through and did the assessment, I was looking at the background. I was seeing her as a physician. It turns out there's some chronic depression. And chronic depression is an alarm bell. Major depression that occurs, that happens. It's a whole other discussion in seminar. But chronic dysthymia or depression is often an indicator of early childhood trauma. As is, she has some cluster B traits, some impulsivity, some drama, and other things that had gone along with that. And it turned out there was a sensitive claim, which in New Zealand means there had been an episode of sexual abuse, and that you can claim and get support from that from the national government to get psychotherapy around that when she had been aged 11. And that was, again, is just another warning bell that's telling me there's an early childhood vulnerability here that is helping me to better explain the symptoms than the shell falling on her head, which is just the trigger. And after we had an assessment, I went through, and I sort of thought I was pretty confident where things were going, and I put together the report and sent her a copy for her to look at before I sent it in to the reviewer, which was an insurance company that asked me to see her as a physician. She wrote me this email and said, "You were correct in thinking there was more to my story than what I've told you. I'm ashamed and embarrassed by my past. I had an eating disorder and drug and alcohol problems, all for around 5 years. I moved countries to distance myself from my family. I didn't trust my parents myself for over 20 years. I've done therapy as I want to live a healthy life. But after seeing her, I realized I need more help. I have trouble opening up to people, which hinders my progress." I haven't fixed her. I haven't even really helped her in terms of her symptoms. But the assessment and going through and asking the questions that we went through in a structured way and being validating about her symptoms has enabled her to take a moment of pause to think about the nature of the symptoms she's experiencing. This isn't magic. You don't have to be a psychiatrist to do this. You have to be authentic and present in the room. You have to ask questions and be willing to hear the answers. And sometimes they'll be uncomfortable, and just accept that and say, look, I don't know exactly what's going on here, but here's the pattern that I'm seeing. And I'm concerned and I want to help you, and here are some things that we could potentially do. Patients in this case don't want brilliance. It's not like a Hollywood moment where we hug, the sun comes through the clouds, we take a walk around the duck pond, and everything is better. That email was the start of her journey, and to go through towards people like Christy and Megan who can actually do a lot of good in terms of helping her. The big question I get from physicians and colleagues, and whenever this comes up, is, what if we miss something? And, I need one more MRI, even though she's had 3 others, or I need a second porphyria screen, because you can never be too sure. And I love the wild and wonderful. I mean, having come from a diagnostic service, it's a great feeling when you make the catch. But the reality is that it is rare, and it's gotten rare. This is data from the 90s showing with the advent of modern radiology and modern laboratory studies, our chance of missing diagnosis of it being Castleman's lymphoma or atypical presentations of atypical diseases are very rare, as long as you see the pattern. And the key thing here is that it doesn't matter. You can be wrong, because you're not warehousing them. You're not saying, oh, you have a functional disorder, don't darken my doorway ever again. You're saying, I think there may be a functional component in terms of the feedback system that's occurring that's causing these organs to be affected and causing you to have real pain. I think we need to follow you closely and also make sure we're getting help at the same time that impacts your feedback system and helps you to alleviate some of these symptoms. But these patients actually need to be seen more frequently, not less. And sometimes when there's a lot of health anxiety involved, I'll ask them to see their GP on a regular basis, need it or not, to make sure that they have good contact, because functional patients have MIs. Functional patients have PEs. Functional, just like people with drug abuse, they break bones, and they need opiates. Functional patients get real symptoms. How do I differentiate? I focus on the objective. At the bottom of my notes, I say, look, and I would like, in the future, the patient will benefit from having a regular relationship with a clinician who understands them and knows them and can have an authentic conversation. Oh, this isn't like my usual pain. This chest pain feels different. Or if they're just coming to the emergency room, I say, please make sure they get an appropriate objective clinical workup, such as chest x-ray, clinical exam, OBS, TROP, chem, FBC, but consult carefully or consult with liaison psychiatry or have an SMO review, at least, before doing a CTPA or a VATS or some other esoteric investigation or procedure. I'm not saying don't provide care for them. If anything, they need more care during the period of treatment, because they will have more symptoms during that period. The Danes, who have the best cohorts on this, have looked at 5,400 patients they've put through an evidence-based treatment approach. They have a 70% treatment rate on an intention to treat analysis. And so if you look at patients who actually stayed with the treatment course through the whole time, it approaches 90%. They looked through their treatment cohort, and after 2 years, they had missed 3 diagnoses. And all the diagnoses were secondary soft tissue injuries that were misattributed to secondary functional symptoms that later turned out to be sprains or, in one case, a disc irritation. And there were no primary weird and wonderful disorders among those 5,400 patients that had been missed, because they weren't making the diagnosis off the cuff. They were doing it in the setting of a thoughtful assessment and continued follow-up. Do we have any evidence-based assessments? Yes, we do. We know there is the largest effect size is for psychological input from Danish, German, and other cohort studies. The moderate effect size is from exercise, and the smallest effect size is medication. There is data suggesting that a tricyclic antidepressant or an SSRI can be useful in some cases. Because it's the smallest effect size, I am very willing to give it up And I explain to patients, you know, we can help you. We're going to continue to follow you from a medical point of view, or I'm going to have your GP continue to follow you, or I'm going to continue to follow you. And we're going to go through, in terms of treating this feedback system disruption that manifests as the functional disorder that's causing the symptoms that are bothering you the most right now. The biggest benefit is going to be from psychological therapy to retrain that feedback system. There's going to be a strong benefit from exercise. There are studies that show that a medication like an antidepressant can be helpful in helping brain modulation in that feedback system. But if they show any hesitation or concern or distress, or I don't want drugs or medication like that, I'm very happy to back off and give them some agency, because the effect size is so small in terms of the benefit of that. And it also gives me something if later on they come and say, you know, my symptoms are partially resolving, or I'm not really getting better. I can say, well, you know, from an evidence-based medicine point of view, there is the medication which we haven't tried, which could offer you some benefit. So what can you do in the setting with your patients? Communicate. Take them seriously. Accept that these are real symptoms, it's real pain, it's disabling, that people with chronic fatigue have to work at 130% to produce 70% of their effort. And it's exhausting for them, and it's brutal, because they often look fit or attractive or capable, and people don't understand why they're having this internal process that means they can't work, they can't take care of the kids, they can't help out. And they live in this world of invalidation and criticism. And hearing from you, it sounds like this has been really awful for you. It sounds like the fatigue has been exhausting for you and stopping you from doing things you want to be able to do, is extraordinarily powerful. Value your time and your compassion with your patients. Sometimes that's the main thing that's needed. But if the pattern continues, don't be afraid of the diagnosis or to bring it up. Look, I want to make sure we're not missing anything. The differential diagnosis could include that we're missing something more serious that's affecting your gut, but it may also include this maybe a functional problem between the gut and the brain, and we want to make sure we're not missing that, and because I want to make sure I can do everything I can to help you. What you can do in terms of treatment, a management plan, communication is critical. Don't just have it in your head, or just, you know, at the top of rounds, cleverly give it to your registrar, but make sure it goes in the paperwork and make sure you therefore talk to the patient about it, and it gets communicated to the GP. Refer to psychology and discuss what that would mean to your patient. Refer to exercise physiology. Don't be afraid to contact your colleagues and liaison psychiatry, and make sure you treat the whole person about that. And recognize it does take time. It is impossible to do these kinds of assessments in 10 to 15 minutes, and you're going to either have to make time or bring them back or accept your inability to effectively address this common and severe problem. But with time and energy, you can have an enormous impact on your patients who have these frequent issues, who have these symptoms, and you can make a real difference in their lives. What's helpful? Psychological therapy, physical training, medicine, not helpful, more investigations, esoteric approaches, and things like that. So to go forth and talk about what's helpful, bring up Beacon.